Good morning, everybody. I request our beloved President, immediate past President, our oration committee nominee, Dr. Pratibha, and our first oration awardee, Dr. Jyotirmay Biswas, to come on stage, please.
So good morning, everyone. It's indeed my pleasure to invite all of you for this general body. I call the meeting called to order. We'll start with the welcome note. So indeed a great pleasure to take over as the 70th President of Tamil Nadu Ophthalmic Association. Thank you so much for this opportunity and honor. Let's move on. Because of want of quorum, we've delayed the proceedings by 15 minutes. And let's move on with the third agenda, homage to our departed members. I request Secretary to announce the names.
We've lost three of our dear members in the last 1 year. Dr. Ben Ravindran from Nagarkoil, Dr. Sadiq from Erode, and Dr. Kalimullah from Vellore. I request everybody to stand up and observe 1 minute silence in memory of the departed souls. Thank you. We'll move on to the orations. The first oration will be the Dr. Joseph GNANADICKAM Oration Award. Video, please. Thanks to Dr. Deepak of Joseph I Hospital for preparing a nice introductory video about Dr. Joseph, his life and his accomplishments, his connection with TNOA, and the reason why the award was instituted.
In ophthalmology, a visionary figure emerged, leaving an indelible mark on the field and on countless lives. Dr. Joseph GNANADICKAM, born on the 14th of July 1900 in Coimbatore, India, began life amid challenges, losing his father even before birth. Raised alongside his sisters by a dedicated and resilient mother, Dr. Joseph's character was shaped by compassion and fortitude. In 1919, his journey in medicine commenced as a military pupil at the Royapuram Medical School. With unwavering dedication, he earned his medical diploma in 1924, setting the stage for a remarkable career that would redefine eye care in India. He then went on to pursue higher medical education and ophthalmology training at several centers in Europe, including Vienna, Paris, and Berlin. These formative years enriched his expertise and nurtured his passion for advancing eye care. In 1934, Dr. Joseph arrived in Trichy, a city where he would etch his name in the hearts of countless patients. Together with his wife, Mrs. Soundaranayagam, he established the Dr. Joseph Eye Hospital in 1936, a beacon of hope and healing for those afflicted with eye ailments. But his aspirations transcended the walls of the hospital. He was one of the pioneers to introduce community-based eye camps for the poor and needy. Driven by a deep sense of responsibility to the visually impaired, he founded transformative institutions such as the High School for the Blind and the Bishop Deal Rehabilitation Center. His unwavering dedication also led to the creation of the Orbit Workshop for the Blind and a rehabilitation center for blind women in Trichy. In 1951, Dr. Joseph's vision extended beyond Trichy when he invited ophthalmologists from all over Tamil Nadu to gather for an informal meeting to share his vision. Inspired by his proposals, the Madras State Ophthalmic Association was born in 1952, uniting both private and government eye surgeons in the state to serve rural communities through fellowship, eye camps, and educating the masses about eye care. It was this association, started by him, that has grown into our present-day Tamil Nadu Ophthalmic Association, the TNOA. The year 1962 witnessed an act of unparalleled generosity when Dr. Joseph selflessly dedicated his privately owned Joseph Eye Hospital to the Tamil Evangelical Lutheran Church. This transformed the hospital into a charitable non-profit institution, ensuring it served all, regardless of caste, creed, or affordability. He went on to occupy several prominent positions both state and nationwide, including the president of the National Indian Medical Association, a testament to his leadership and influence in the medical community. Dr. Joseph's life journey came to a close on the 14th of January 1983, leaving behind a legacy that continues to inspire eye care professionals worldwide. The annual Dr. Joseph GNANADICKAM Gold Medal Oration Award was instituted in 1983 to honor his pioneering spirit and exceptional contributions to ophthalmology. Every year, this award is presented to remarkable individuals who exemplify the same values and attributes that define Dr. Joseph's life: a profound commitment to patient care, dedication to advancing ophthalmology, and an unwavering passion for serving those in need. In honoring these recipients, we pay tribute to the enduring legacy of Dr. Joseph GNANADICKAM. As torchbearers of his vision, they continue to make a profound impact on eye care, improving lives and ensuring that the gift of sight reaches every corner of society.
I now request Dr. Pratibha, Director of Joseph Eye Hospital, to introduce the awardee.
A pleasant morning and a pleasant day ahead to one and all gathered here. I, first of all, on behalf of TNOA and Team JEH, the Joseph GNANADICKAM Memorial Committee, I congratulate Dr. Jyotirmas J. Biswas for being the awardee to the prestigious Dr. Joseph GNANADICKAM Gold Medal Oration Award. So, Dr. Biswas. Okay. It's not going somewhere. It's not going. Yeah. So, Dr. Biswas completed his fellowship training in vitreoretinal surgery from Shankaran Nethralaya, and he obtained further specialization in ophthalmic pathology from TNOA Eye Institute. He has published 504 articles in index journals, 65 chapters in the books of ophthalmology, and he has presented over 300 papers in national and international conferences. He has authored 5 books on uveitis and 1 book on ophthalmic pathology. He is a visiting professor at the Advanced Eye Care Center at Postgraduate Institute, PGI MER, Chandigarh, and the Chinese University of Hong Kong. He is a proud recipient of as many as 50 awards, including the prestigious Alembic Research Award from the ICMR, given away by the Honorable President of India. He is a member of the International Uveitis Study Group, American Uveitis Society, and the International Ocular Inflammation Society, and is a fellow of the Indian College of Pathologists. He is a founding member and the past president of the Uveitis Society of India, and he is a founding president of the Society of Inflammation and Research. He was the first to describe ocular lesions in AIDS in India. And he has been ranked in the 8th position amongst the top 2% of Indian researchers in ophthalmology by the Stanford top-rated research ranking. Currently, he is the Director of Uveitis and Ophthalmic Pathology Department at Shankara Nethralaya, Chennai. So we are proud to present this prestigious award to Professor Jyotirmay Biswas, and we wish him success in his future endeavors.
Good morning to all. Thank you, Dr. Pratibha, for a kind introduction. I never thought 38 years back in 1985 when I participated in TNOA conference in Tanjavur, I didn't have any presentation. I didn't know how to make a presentation or make a paper. Today I'm standing in this podium to give the prestigious Dr. Joseph GNANADICKAM Oration Award. What a magnanimous personality and what a glorious career he had, and to be recognized and selected for this award committee for delivering this Joseph GNANADICKAM Award, Gold Medal Oration Award. I feel very honored and feel very humbled today in front of all of you to share my thoughts on ocular tuberculosis. So, as has been mentioned about Dr. Joseph GNANADICKAM, a wonderful video, I'm not going to talk about Dr. Joseph GNANADICKAM much. And he was born in 1900, and his career and everything has been told in the nice video. I straight go to that my talk. And today this Joseph Hospital stands and is a tribute to the community, to the service of as a recognition of his wonderful services. So the previously about 38 people have received this Joseph GNANADICKAM Oration, Gold Medal Oration Award. There are several luminaries. I feel very humble to be among them. My mentor, Dr. S.S. Badrinath, was one of them, and today I am talking in front of you in TNOA audience about my work in tubercular uveitis. I dedicate this oration to my mentor, beloved Chief Padma Bhushan, Dr. S.S. Badrinath. Without him, I wouldn't be here. And what I have learned and what I am today is due to this great personality. Today the topic which I have chosen is battle against ocular tuberculosis, 3 decades of my research. Why I chose ocular TB? TB can affect any part of the eye. TB uveitis has protean manifestations, can have varied presentation, and can be blinding also. TB in the eye is still an unsolved mystery. My journey of ocular TB research started when I joined Shankara Nethralaya, the Temple of the Eye, as a consultant in 1985. And so far I have published 83 articles on ocular TB. So I thought that it would be apt to discuss about my research work on ocular TB. I planned my talk in this way: tuberculosis prevalence in India, tubercular uveitis, anterior, intermediate, posterior pan-uveitis, tubercular retinal vasculitis, tuberculous scleritis, and rare entity conjunctival tuberculoma. I'll be talking briefly about imaging in TB uveitis, laboratory investigation, radiological investigations, new in management of ocular TB, research on ocular TB. There are several pioneers in this field, but I am going to restrict my talk about my work only and show few cases with you. Let me start with a case. About 30 years back, I saw this patient, 42-year-old woman, dimness of vision in the right eye for 15 days, developed exudative mass near the macula, had raised serum angiotensin converting enzyme, and positive QM test. QM test was used for sarcoidosis that time, and the patient was treated with high dose of oral steroid elsewhere, and came with multiple subretinal abscess. And you can see this in this picture, the multiple subretinal abscess in the retina. The eye could not be salvaged, unfortunately. It became painful and blind and need to be eviscerated. But when I looked under the microscope in eviscerated tissues, I found myriads of acid-fast bacilli in the subretinal space. It amazed me. I thought that how can be the tubercle directly infect the eye without infecting other parts of the body. In fact, TB is really a diagnostic dilemma. TB or not TB is a perennial question. Which one to call TB, which one not to call TB is a real challenge. And there is a controversy in ocular tuberculosis in the terminology itself, diagnosis, treatment. So it would be apt to discuss some of these aspects in this oration. So how common is TB? TB in India is endemic. 2 million people develop TB every year in this country. Every fourth patient of the TB in the world is an Indian. Let me share my humble experience. It was 1985. I had just joined as a consultant after my vitreoretinal fellowship. I didn't do the vitreoretinal surgery. I took up a uveitis services. I was given a research project, ocular morbidity in active systemic tuberculosis. I asked the questions, what is the ocular morbidity in active systemic tuberculosis? What are the various types of ocular tuberculosis seen? Is Eales disease seen in active systemic tuberculosis, which is often thought to be due to tuberculosis? And I spent 1 year in tuberculosis research center in Chetpet, Madras, and I studied 1,005 patients in TB hospital in 1 year. Ocular morbidity in active systemic tuberculosis was surprisingly low and was 1.39%. Most common was healed focal choroiditis, and surprisingly, no case of Eales disease was seen. And this is a miliary tubercle of the choroid, which I have seen one of the patient. I brought the patient on an auto from Chetpet to Shankarnetralaya to take the photograph. And this is a miliary tubercle of the choroid, a rare photograph of a ocular tuberculosis. I published this article in International Ophthalmology, Ocular Morbidity in Patients with Active Systemic Tuberculosis. When I looked into my uveitic clinic registry, I found in 1992 it was 0.64%. Because it was only chest X-ray was used, only clinical acumen was used to underdiagnose ocular tuberculosis. But when with the advent of high-resolution CT chest, PCR and ocular tuberculosis, we found actually tubercular uveitis is not that but uncommon. It is about 22.5% found in 2018. It could be anterior uveitis. Let me show an example. 20-year-old female with granulomatous anterior uveitis, as you see in this picture, with mutton-fed capes, broad posterior and peripheral anterior synechiae. Is it TB? Yes, it is TB, because the PCR for mycobacterium tuberculosis using MPB64 and IS6110 region was positive. Patient responded to a course of antitubercular treatment. What about this patient, 40-year-old man, no systemic history, And is this TB? Yes, this is also TB. Direct smear culture and PCR was positive, and it was published in American Journal of Ophthalmology case report. Tubercular uveitis presenting as a pigmented hypopion, which is one of the very, very rare phenomena. Only other case was reported by Professor Ratnam from Arvind High Hospital, Madurai. And here is the case, full chamber, almost full chamber pigmented hypopion, and PCR showing mycobacterium tuberculosis DNA. Can intermediate uveitis be TB? This 14-year-old girl, bilateral intermediate uveitis, is it due to TB? Yes. High-resolution CT chest showed pulmonary infiltrate in the lung parenchyma, and real-time PCR from the acetap showed 2,204 copies of the mycobacterium tuberculosis DNA. And this, in fact, we have found 22 eyes of 14 cases in our center which are found to be PCR positive for mycobacterium tuberculosis. This is one of the cases. You can see the spillover granulomatous anterior uveitis, and the patient had in the vitreous cavity inferior snowball exudates and the peripheral vitreous membranes. We did the PCR from the vitreous study, and we found nested and real-time PCR. Both was positive for mycobacterium tuberculosis DNA. In fact, we could do that cytopathology of the vitreous exudates, and in a case with a dense vitreous opacity of these patients in the right eye, and this patient had undergone a vitrectomy, and this vitreous aspirate showed granuloma, suggestive of a tuberculosis, and PCR was positive for mycobacterium tuberculosis DNA also, thus confirming a tubercular intermediate uveitis. Can posterior uveitis be tuberculosis? And this is a patient who presented with a choroidal nodule and is a 26-year-old woman, and this patient had fundus examination, so was left eye showed choroidal tuberculoma. Is it TB? Yes. That lung radiological investigation itself has showed that the patient had miliary tuberculosis. In addition, the patient has got tubercular lymphadenopathies, which on cervical lymph node biopsy showed necrotizing granulomatous inflammation. Clinical profile of intraocular TB is very challenging. It is a great mimicker of various uveitis entity and can be vision threatening, as I mentioned to you. And I show a case where the patient was having a granuloma on the optic nerve head and perivascular sheathing and chorioretinitis patches with retinal hemorrhages. Lung lesion responded to antitubercular treatment, but ocular infection did not, and it led to the panophthalmitis and then ultimately phthisis bulbi. And the eviscerated tissue showed plenty of acid-fast bacilli. When we looked at our pathology department registry, we could find out only 5 cases in 10-year period which has got pathologically or microbiologically proven tuberculosis. And this subretinal abscess was 2 cases, granulomatous uveitis with scleral perforation 1 case, exudative mass in the anterior chamber 1 case, choroidal mass with panuveitis 1 case. Only 5 cases in 10-year period. So direct invasion of the tuberculosis in the eye was not that very common. And this is one of the patients, as I showed to you, has a subretinal abscess with acid-fast bacilli in the eviscerated tissues. Can panuveitis be TB? Is that one? We have 3 cases of tubercular panuveitis, while mycobacterium tuberculosis genome was detected by nested and real-time PCR. Acid-fast bacilli was seen only 1 case in the retinal pigment epithelium. This is a patient of 25-year-old male who had dimness of vision for 6 months, Manto positive, CT chest normal. In spite of ATT and steroid, patient lost vision. Occlusive pupil and rubeosis iridis seen, eye became painful and blind, and we thought that is it due to TB? Enucleated globe on histopathological study showed lymphocytic infiltration throughout the retinal layers and uveal tissues with caseation necrosis, as shown in the arrow, that this is very suggestive of tubercular infection. And on the top of it, the PCR was positive for mycobacterium tuberculosis from the paraffin section from the eyeball, which was enucleated. PCR-proven tubercular uveitis can be seen in the 25-year-old female, and this patient had obviously TB spine, pot spine, and this patient in addition has choroidal tuberculoma. And this choroidal tuberculoma responded with the antitubercular treatment, and we did the anterior chamber tap, which showed 81 copies of the mycobacterium tuberculosis DNA. And what has happened to the patient? After anti-TB treatment, there is a complete resolution of inflammation. Tuberculosis can present as subretinal abscess. We have seen 12 eyes of 12 patients in 10-year period of time, and all of them responded to a course of antitubercular treatment with a steroid. I show an example. This is a 19-year-old girl from Uttar Pradesh, had got a subretinal abscess, and what we did is a fine needle aspiration biopsy, and it took us a lot of dexterity. Dr. Mahesh Shamugam at that time was with us, and who did the sample from the FNAB. And that tiny sample of the FNAB material showed PCR mycobacterium tuberculosis DNA. Look at the patient, what has happened. After 3 months, there is a complete resolution of inflammation with subretinal abscess, complete absorption. This is a 33-year-old male with active amphigenous choroiditis. What is the cause? This was also found to be TB, MPB64 genome for mycobacterium tuberculosis was positive. This was published in Ocular Immunology and Inflammation, nested PCR for amphigenous choroiditis positive. Multifocal serpeginoid choroiditis was now thought to be of tubercular etiology. But before that, we could find out the PCR positivity from a case of a multifocal serpeginoid choroiditis by PCR study. And this is a case of miliary tuberculosis with a pan-uveitis. From the pan-uveitis eye, we could find out the mycobacterium tuberculosis DNA, indicating that this is indeed due to tuberculosis. Retinal vasculitis can be due to TB. This is a 17-year-old girl, very rare case, is the frosted branch angiitis presentation, and this patient had abdominal tuberculosis. What we did, we just treated the patient with anti-tubercular treatment and steroid. Whole frosted branch angiitis completely disappeared, and the vision has completely improved. And this was published in retina case BIF reports. Eels disease is always a dilemma in the etiology. In 1880, Henry Eels described this disease in Birmingham, and he thought that it is a vasomotor neurosis. Wadsworth 5 years later told that it is an inflammation. But nobody knew the cause. It is one of the most common cause of retinal vasculitis in our country. 1 in every 135 eye patients in Shankarnetralaya was found to be up due to this disease. Can Eels disease be due to tuberculosis? There is no way we could find out unless we go into the tissues. We took the vitreous sample of the patients who has undergone vitreoretinal surgery, and we found 5 out of the 12 samples, almost 50% of the cases were positive for tuberculosis DNA. None were cultured positive. This was published in British Journal of Ophthalmology. We also found that the polymerase chain reaction from the detection of mycobacterium tuberculosis DNA in epiretinal membrane of Eels disease patients, and about 47.8% of the epiretinal membrane of the Eels disease was positive for mycobacterium tuberculosis. And in fact, we could find out, we hit the jackpot when you could find out the actual tubercle DNA in the ocular tissues of the enucleated eyeball of a case of Eels disease. And we could postulate that there is a cell-mediated immunologic reaction triggered by sequestered mycobacterium tuberculosis antigen causes Eels disease. We did the histopathological, immunohistochemical, and molecular biologic study of enucleated specimen of a case of Eels disease. We found CD68, CD3, and CD8 cells positivity, indicating immunomodulatory reaction in the pathogenesis of Eels disease, particularly T suppressor cells involvement. And this patient was positive for mycobacterium tuberculosis DNA by polymerase chain reaction also. Further evidence of association of latent mycobacterium tuberculosis in Eels disease, we found MANTO positivity in 73% cases, quantiferon TB gold test 56% cases, HSCT test 34% cases, aqueous PCR 33% cases, vitreous PCR 22% cases. We compiled our data and published a review article in Eels disease and update in Survey of Ophthalmology in 2002, and this was a landmark article on Eels disease. And after 11 years, we described the current concept in the diagnosis and management of Eels disease, and we postulated that based on our molecular biology study, each disease should be considered to the tubercular retinal vasculitis based on that molecular biologic study, which was a great breakthrough in the understanding of this enigmatic disease. Tubercular scleritis, this is a patient which amazed me, and this patient had rheumatoid arthritis. We thought that this is due to the rheumatic disease, autoimmune disease. We treated with the steroid, immunosuppressive agents, IVMP. The patient did not respond, lost follow-up, came with a perforation of the globe. Eye became painful and blind and enucleated. When we looked at the enucleated globe histopathology, we found that there is a granuloma formation to the giant cells with a non-granulomatous inflammation. And this patient was positive for mycobacterium tuberculosis DNA, was positive for mycobacterium tuberculosis DNA from the paraffin section, indicating that the scleritis, which I thought to be autoimmune, was due to tuberculosis. And this was published in Ocular Immunology and Inflammation. We could found out a case of a tubercular sclerouveitis which presented as an ocular tumor, and the eye was unfortunately enucleated. Enucleated globe did not show tumor, instead it showed chronic granulomatous inflammation. PCR from the paraffin section was positive for mycobacterium tuberculosis DNA, indicating that the tumor was due to tuberculosis, not due to tumor. The mass was due to the tuberculosis. This is a case of a conjunctival tuberculoma, 26-year-old female, history of swelling for 1.5 months, marked diminution of vision in the left eye, 7 days. It was thought to be by clinician as the squamous cell carcinoma of the conjunctiva. And we did that enlarged periauricular and submandibular lymph node further increased the suspicion. But when we did the conjunctival mass excision and under local anesthesia, we found there is a granulomatous inflammation with the giant cells with caseation necrosis, indicating that is a tubercular infection, and this was positive by PCR study also. This is I talked about tubercular anterior uveitis, tubercular intermediate uveitis, posterior panuveitis, retinal vasculitis, tubercular scleritis, conjunctival tuberculoma. And now a little bit about the imaging in tubercular uveitis. Simple fundus photograph morphology phenotype can be useful for understanding the tubercular etiology, autofluorescence, FFA, ICG, and SSOCT. And here is a patient presented with a tuberculoma of the choroid, and fundus fluorescent angiogram showed initial hypofluorescence, later hyperfluorescence at the rim, and showing a ring of fire appearance, which is very typical of TB choroidal granuloma. We also did the swept source optical coherence tomography to prognosticate this disease and to document the serial progression of the disease. And we could see that the contact sign is present over here, and this goes, this becomes flattened with the course of treatment and the progression of the disease. Regarding the laboratory technique, Mantoux test, quantiferon TB gold test, polymerase chain reaction, which we are using for the diagnosis of tubercular uveitis. Is quantiferon TB gold test better than Mantoux test? It's a one-time test, and we found that the sensitivity and specificity is much more than Mantoux test. We also did the study of polymerase chain reaction in the intraocular fluid from the suspected tubercular uveitis. We found that the sensitivity is 80% and specificity is 100% of the cases. And this is a polymerase chain reaction for mycobacterium tuberculosis DNA from the ocular fluid in patients with various types of choroiditis with spillover anterior uveitis. And we found subretinal abscess 87.5%, choroidal tuberculoma 50%, and miliary tuberculoma of the choroid PCR was positive in 100% cases. Radiological diagnosis, we found that if we do X-ray chest, it will miss 40% of the tuberculosis. And we found that the role of high-resolution computerized topography of the chest in granulomatous uveitis, particularly in TB and sarcoid, 81% TB and 8.3% sarcoidosis could be detected by high-resolution CT chest. New in the management of ocular tuberculosis, in spite of anti-tubercular treatment for drug, a lot of patients do not respond. We have treated a patient with choroidal granuloma and subretinal abscess with intravitreal bevacizumab 0.05 ml and intravitreal moxifloxacin 500 microgram in 0.1 ml every month, and the patient showed complete regression of the inflammation. with the scarring. And this was published in Ocular Immunology and Inflammation. Ocular TB in HIV is a different ballgame. It can have myriad of presentation, starting from small tuberculoma of the choroid, subretinal abscess, conjunctival tuberculoma. 1.9% patient of HIV with ocular lesions can have tubercular ocular lesion. And this most common is the choroidal tubercle, followed by the subretinal abscess, panophthalmitis, and conjunctival mass. There can be a double trouble. The same patient can be having tuberculosis as well as a cytomegalovirus retinitis and need to be treated for both. In the research front, we are now working on multiplex PCR to differentiate between the tuberculosis and non-tubercular mycobacterium tuberculosis to identify the various strains of mycobacterium tuberculosis DNA. What I am doing now is the flow cytometry of T regulatory cells in presumed tubercular uveitis, and this is a basic science study. And our study showed that the TREG markers CD4 plus, CD25 plus, and FOXP3 plus were higher in the presumed tubercular uveitis. There's the green channels showing much more increase than comparison to the control. In conclusion, ocular TB is still a diagnostic and therapeutic challenge. Pathogenesis of various types of ocular TB is still not clear. A lot of research still needs to be done, needs a more sensitive and precise test, and needs more targeted therapy. The most important thing, as Albert Einstein has told, is not to stop questioning, and in case of tubercular uveitis or ocular tuberculosis, it is very true. So at the end, I'd like to thank ASN family for their support, and Dr. Joseph GNANADICKAM committee and the TNOA for choosing me to deliver this oration. I really feel humbled and very honored to deliver this oration. Thank you very much. Thank you all for patient hearing.
Thank you, Dr. Biswas, for the wonderful oration. And you are indeed a pioneer and authority on ocular tuberculosis that was reflected in your presentation. And this oration recognition reflects the impact of your valuable contribution to the community and fraternity. Thank you so much.
Thank you very much.